Okay, good. And hopefully you guys can see me. Sorry, I'm like outside. But my name is Armika Tatum. I'm a recent graduate from Ohio University Heritage College of Osteopathic Medicine. And I'm actually going to do my residency in family medicine. So I'll be starting as a family medicine doctor here in just a couple of weeks. And so I actually wanted to get started because I wanted to give a little bit of background about my experience like with strokes. And Dr. Biru, she'll actually talk about, that's like her specialty is neurology. So I'm just going to give a little information about my mom. My mom passed away in 2018 and it was complications after having a stroke. And so with her story, she actually was initially diagnosed with diabetes, I say like 10 years prior to her passing away. And sorry about that, guys. I'm like outside of Panera. But so she was diagnosed with diabetes and she let it go basically uncontrolled for years, ended up having kidney problems as a result of it. And for a lot of people that may not know, your kidneys are one of the main organs that actually helps regulate your blood pressure. So years later, after her being diagnosed with diabetes and not really taking care of the diabetes, her blood pressure ended up kind of spiking quite a bit. So over the years, she also didn't take medicine for the high blood pressure. With her not taking care of the blood pressure medicine, she ended up seeing a nephrologist, which is a kidney specialist. They eventually convinced her that she needed to be on medication. She started taking a medication, which is the drug class is called ACE inhibitors or angiotensin converting enzyme inhibitors, very common medication. And then she actually ended up experiencing like some of the side effects, which is like cough, like a dry cough. And because she was experiencing those side effects, she decided, hey, I don't want to take this medication anymore. So because of that, her blood pressure just kept increasing and increasing. And long story short, she was out at Costco one day in February and ended up like having her blood pressure go so high that her blood vessels in her brain burst and had a stroke. Was rushed to the hospital, was kind of on a ventilator for a while. She was on the ventilator in ICU for 30 days down in Cincinnati, which is my hometown. After that, she was basically transferred from different facilities, tried to restore some of her function. She was paralyzed on the left side. And like I said, ended up passing away just because of some complications because of the stroke. So that was my mom's story about like having a stroke. That was like what we call like major stroke that she had. She did have some other events, and we'll talk about it, called like a TIA. And today, Dr. Biru, she'll actually talk about that and what that is a little later in our conversation. But she did have like those type of complications before having that major stroke. So I'm just going to go ahead and give the mic over to Dr. Biru.
Hello, everyone. Can you hear me? Awesome. Thank you. Thank you, Armika, for the introduction. As she said, my name is Dr. Tsedey Biru, and I am a neurology resident at Kettering Health. It's a network in the Dayton area. So I am finishing up my first year of residency in neurology here in the next month or so, and I'm very excited and honored to speak with you guys about strokes. I want this to be more informative and as beneficial as especially when it comes to learning how to prevent strokes, and so that we don't have to deal with the complications that come after. So that will be some of the information that I'll be sharing, and I will try not to get into too much detail about this. And if anybody has any questions or concerns or anything like that, we can always address those as they come. So I guess I'll start first by just talking about what a stroke is. And Dr. Armika Tatum has some questions as well. We want this to be more of a question and answer kind of session so that everybody can participate and you guys can ask questions, and it will be more informative that way rather than me just talking. So I will start by just giving a little bit of an introduction, I guess. So strokes are very common, and unfortunately, African Americans or people of color have the highest rates of stroke and stroke complications. They are 50% more likely to have a stroke as compared to their other white adult cohorts. So it is very important that we do talk about this, as well as learn to figure out how we can deal with the risk factors of stroke so that we can prevent strokes from happening, as well as dealing with the complications later. So when we talk about stroke, basically there is an interruption to the blood flow going to your brain, and of a couple of different reasons. Either there's a blockage in the blood vessels that are supplying to your that are supplying blood and the nutrients and the oxygen to your brain. Either they're blocked, or as Armika just described with her history, or with her trauma that she experienced with her mom, there could also be interruption in a sense of a bleed as well. So when there is that interruption, our brain cells are truly reliant on oxygen coming from that blood, so they start to die off. And our brain cells particularly are very sensitive, so within seconds, minutes, more and more brain cells start to die off. And if we do not restore that blood flow, then the severity or the damage can enlarge, and it can affect more of our brain areas. So that is basically what a stroke is in a general sense. And there are two kinds of strokes, just like what I just mentioned, ones that are caused by blood clot happening, and then the other ones that can happen when the blood pressure in the brain is just too high, and our blood vessels cannot sustain that, resulting in a bleed. And there are several risk factors for that can result in strokes that as well. That in a way is kind of a puzzle. So our brain controls all of the muscles in our body, as well as our swallowing muscles, our movement muscles, our sensory information. So basically the brain is the powerhouse of our body. So when that blood flow is interrupted, and when those brain cells that start to die off, then we lose function. And that's why the complications that come after, such as not being able to move one side of your body, not being able to feel one side of your body, difficulty with swallowing, difficulty with speech, and all of those other things come up after that, depending on what area of the brain is damaged, as I guess as a repercussion of the stroke that might have happened. So that is the general gist of what strokes are. And I guess me and Dr. Tatum will kind of go back and forth as to some of the questions that she has, and then we also have somebody monitoring the chat as well, so that they can let us know of any of your questions, and we can kind of go from there as well. So
one of the first questions I wanted to start off with, because you did mention there's some patients that actually can't move like certain parts of their body. If they don't have a stroke where they're actually paralyzed on like one side or have those type of deficits, what are some other things that the person should look for, or like family members that may be around the person should look for?
So as I said, strokes can manifest any sort of ways, and how we kind of localize where the deficit might be is by figuring out what the patient's symptoms are. A lot of the common symptoms that we see are either sensory loss or motor loss. Again, not being able to move your arm those are a couple of the big signals. The other is not being able to talk, not being able to understand others talking well. Those are a couple of other signs in addition, because again, the part of our muscles that are controlled by that side of the brain are not going to be functioning or communicating. You can see a facial droop in a patient on one side or another. You can see some confusion that also could be a part of a stroke as well. Again, confusion could be of multiple, of course, sets, because you may not be understanding when other people are talking to you because your language centers are affected, or you may not be able to communicate your needs to others as well. So confusion can be a part of a stroke symptom. The other things that we see again are like dizziness, severe dizziness, depending on if it's the back area of the brain or the posterior area of the brain that's affected with the stroke, that can result in that as well. So there's several kind of symptoms, and how we generally deal with the symptoms is, again, because we know a particular blood vessel supplies to a particular area of the brain. Usually when these symptoms happen, they happen in culmination. For example, one side of your brain is supplying motor function to your arm and face, as well as speech. And then another part of your blood vessel that supplies to a certain area of the brain controls your leg muscles. So just like we learned in school, and as some of you guys know, that's how we put together a patient's symptoms and try to figure out which blood vessel particularly may be affected. So again, symptoms can be very generic, but usually when strokes happen, they're very abrupt onset. 1 minute the person was absolutely normal and talking normal, or able to move normal, and all of a sudden you have these deficits that come at you, because when these blood clots happen, the brain again is very sensitive and reacts like that. So those are some of the beats of your body: having a facial droop, confusion, non-relenting kind of dizziness to where everything around you spinning, you're overtly sick, you're nauseous, you're throwing up, you're not even able to leave your eyes open just because everything around you is moving, because some of the areas of your balance centers are affected as well. So there's multiple symptoms that we look at.
And I know people talk a lot about like mini strokes, ones that are more major, to like have a mini stroke or a TIA.
Yeah. So as neurologists actually don't like the term of a mini stroke, but that's the common term that's used by other people. So TIA, or transient ischemic attack, is a stroke that was threatening to happen but did not. So for a brief few seconds, the blood flow to a particular area of your brain is affected, but it didn't get completely clogged off to where that area did not lose blood supply or oxygen supply or nutrient supply. Or if it was a very small amount of blood clot, then it just kind of dispersed by itself and it self-resolved. So you had those symptoms for a few minutes. Usually it's a few minutes, again, because the brain is very reliant on oxygen. It doesn't take a lot for the brain cells to start dying. So usually a TIA lasts under 5 minutes, at the most 30 minutes. And then when those symptoms self-resolve, obviously we do not see a stroke. A stroke is you've had the symptoms, those symptoms stay, as in a symptom does not happen, such as you have speech deficits or motor deficits, they happen and they stay. So that is an actual stroke. Versus a TIA could have been a stroke, but for lucky reasons, that blood clot dissolved and that brain perfusion was restored, and as such, you don't see any deficits, as because again, what happened did not happen, for, I guess, the lack of a better sense. So those are what people term as mini strokes, and we have ways to risk stratify for patients that we truly do believe have had TIAs, because TIAs, if somebody has had a TIA, it's a risk factor for having future strokes. So in terms of medication sense, there are some, there are some medication adjustments that we may make to a patient if we truly did believe that they had a TIA. So yeah, that's how we look at a TIA, I guess. I hope that answers your question.
Yeah, it definitely does. And that's something else that I kind of wanted to mention. This is definitely Dr. Biru's wheelhouse there, but like some of the things that you guys should look out for patients that may have, or like family members that actually may like pass out suddenly, because before the February when my mom had a stroke in 2018, a year prior, she had actually just like suddenly passed out, in which the physicians were saying like it probably was an actual TIA. So she really didn't have that blood supply to her brain, and as a result ended up passing out. So when things like that happen, just make sure that the person actually looks into it more and still goes and sees a physician then, because a lot of people are like, oh, I just, and then they'll go on about their day, which is what happened in my mom's case. And again, it's just not being educated about exactly what could be going on. I also did want to go to someone in the chat actually asked, can a stroke cause a heart attack?
Two different mechanisms. However, the risk factor for strokes and the risk factors for heart attacks are actually kind of similar. I'll get to in just a minute. So heart attack is blood flow getting interrupted to an area of your heart, meaning there is a blood clot or blood flow, a sense of there is some atherosclerosis because of the risk factors that you have, and they tend to be having kind of similar effects. So if somebody has risk factors for heart attacks, more than likely they have risk factors for strokes as well. And these risk factors being high blood pressure, diabetes, high cholesterol, sleep apnea is a risk factor for heart attacks as well as a stroke, and smoking. Those are, I guess, the 5 top risk factors for both heart attacks and so those kind of tend to go hand in hand, but strokes do not cause heart attacks, if that makes sense.
Can you talk a little bit about ways that you can prevent a stroke?
Yes, absolutely. So that's where we should spend a lot of our conversation, because unfortunately, this is the kind of, the sad part of what we do is once strokes have happened, there is very little that we can do about them. And again, there is stroke management in the acute setting, meaning if somebody presented with a stroke and it happened 30 minutes ago, actually within 4.5 hours, we have different ways to treat strokes. So when somebody comes to the ED and we truly do believe that they had a stroke, then as I said, because it's a blood clot or blood flow being interrupted to the brain, there is a clot busting medication that we give within the first 4.5 hours of onset. So with this medication, we have to be very thorough and investigate other things. Everybody that comes to the ED is able to get this medication because it's a clot busting medication, it has bleeding risks, especially if somebody has had previous bleeding in other areas, GI bleeding, brain bleeds, if they've had a stroke within the last 90 days, if they have any sort of clotting disorder, that goes into the technicality of things. But in the acute setting, if we have a clear onset of symptoms for a patient for the first 4.5 hours, there are things that we can do to mitigate at least the damage and help dissolve that clot and help restore blood flow to the brain so that the patient can improve. And after those 4.5 hours, within the first 24 hours after we've passed that, there are things we can do if there is actually a large vessel occlusion that we can visualize when we do imaging. So as soon as somebody presents to a hospital with a stroke, they get a CAT scan of their brain, making sure this is not a bleed, because bleeding strokes and strokes that are caused by a blood clot are handled in different ways. So once we make sure somebody has not had a bleed, then we look at, is there a blood clot that we can visualize in any of the vessels? And if this is, again, outside of that 4.5 hour window, and we are able to see a blood clot, we now have intervention, what we call neurointervention. So the blood vessel specialists of the brain, sometimes either specialists in neurointervention or neurosurgery sometimes does it too. They are able to go in and dissolve or pull out that clot, or go directly to where the clot is and give some of this clot busting medication that we're able to give. That's within the first 24 hours. And if we are able to see there is a clear blood clot that we have visualized with imaging. So those are the first two things that we're able to do if we have, again, if we know when symptoms, and then if we are able to, there is a blood clot right here, this brain area is being hyperperfused. So if we go and do something about it, then hopefully we can at least decrease the deficits that they would have had. And again, there is nuances there that, you know, that are in the details of the other things, but we don't necessarily need to talk about them, because there are areas that we focus on when we do imaging. Is this even worth it to go and pull out the clot? Because if the area of the brain is already hyperperfused and dead, and there is no area that by us going and trying to intervene that we are able to save, then it's more hurt than benefit to the patient. So there is a couple of things that are standardized that we follow by looking at those first set of images that we get. So after that has happened, and if it's unfortunate enough, then again, we are not able to give them that clot busting medication because of several contraindications that are outlined, or if we're not able to go in and pull out the clot and help mitigate some of the damages, then we just have to watch for the patient's symptoms. And then we have to manage their risk factors as much as possible, because once somebody has had stroke, their chances of having further strokes also goes up. So that's what comes to what our major conversation should be focused on. So one of the risk factors for strokes is something that none of us can do anything about, and that's age. So as we get older, obviously, more people above the age of 50, 55, 60 have higher risk of having stroke than young people, or like our age, I guess I should say. Most of the time we see it over 65 more commonly. And that's something that we can't do anything about. The next major risk factor for stroke is high blood pressure. And it's a major risk factor for, again, the bleeding kind of strokes, as well as the strokes that are caused by blood clots, because it can really damage your blood vessels, and your blood vessels, if they're not able to mitigate when the blood pressure is high or low, then that is another risk factor. The next risk factor is diabetes. Again, there's blood vessel damage that happens if a person is diabetic for a long time and their blood sugars are not controlled, their A1C is not controlled, then again, that's more damage that happens. That puts you at a high. The other is, again, high cholesterol, especially the bad lipid that we call LDL. That has to be even within normal LDLs are under 100, but we want that to be even more tightly controlled, simply because that again can deposit within our blood vessels, and then that can clot, and then platelets. Or I don't want to get too technical, but a clot can happen where those blood vessels are damaged, and again, that will interrupt blood flow and strokes can happen. So some of the major things that we can control, and this is all of us, is making sure our blood pressure is taken care of, making sure our diabetes is taken care of, making sure that our cholesterol is taken care of, making sure that smoking wise, that we do not, or cessation of smoking is what we advise. And then the other is also sleep apnea. A lot of people know they snore when they're sleeping. Sometimes they stop breathing when they're sleeping, or their significant other tells them that, but they don't really go and get evaluated for sleep apnea. And we've seen studies that it can actually put you at a higher risk for having strokes as well. But by seeing a sleep specialist, and if you need to be on a CPAP machine, doing that, you are mitigating that risk factor as well. So those are the major things that we have to make sure we are on top of. And as for anything, of course, obesity and being overweight is also a risk factor, and that is in an indirect, such that people that are usually overweight or obese have more than likely have diabetes, or at least they have higher chance of having type 2 diabetes, as well as high blood pressure. So then all of those just happen to be compounded risk factors for having strokes. And like I said a little bit ago, once you've had a stroke, the chance of you having another stroke is also higher. So those are the risk factors. And the other things that we can discuss is there is an arrhythmia or an abnormal heart rhythm called atrial fibrillation. And that is also considered a risk factor for strokes as well. So if you are having palpitations, or if you're feeling like your heart is racing and you're getting short of breath, or if you feel like you're not feeling your normal self in that aspect, definitely going to see your family physician, making sure that there is an EKG done or other workup that is done to make sure that that risk factor is taken care of would also be essential. So those are the major ones. And there are some minor ones that can affect, especially young people, if you have a clotting disorder or things like that, but those are on the minor side of things. And a majority of the strokes that we see are in the older population and that have most of these risk factors, I should say.
And I did want to acknowledge Miss Dorothy Starks. I do see your question. I'm just going to ask her that in just a second, only because we're kind of talking about risk factors. What about genetics? A lot of people talk about genetics. Does that actually play a role in someone having?
Yes, it is. It does. Family history. It's not just the pure genetics of it. However, it's in addition to everything else, such as not just genetics, but if you have high blood pressure, if you have diabetes, just like the risk factors that I just talked about, a lot of times it just tends to compound things. So if you have a family history of strokes, especially if it's in a younger age, we do a different kind of workup to make sure there's not any clotting disorder, or we look at the not so common things that we can look at just to make sure, again, because a lot of the strokes that we see are in older populations. We do that. So genetics becomes important in some cases, but I would say in a lot of cases, it's compounded with the other risk factors that we talked about. So purely genetics, unless it's because of a genetic disorder that you have some sort of blood clotting disorder that makes you more susceptible to make blood clots. And then that, of course, can go to your brain and block the blood flow to that area, and that can cause strokes. And we see that in the younger population.
Perfect, thank you. So I did want to ask a question that was in the chat. Is paralysis from a stroke reversible? And can you also just talk about, that was one of my questions that I had, is just about recovery in general. Is there like a certain time frame, and can you talk about the deficits?
Sure. That's kind of a loaded question simply because not all strokes are the same. So depending on the area of the brain that's affected, depending on how big the blood clot is, meaning proximal blood clots or blood clots in the bigger blood vessels are going to interrupt blood flow to the larger area of the brain. So then you'll have more deficits from that, as opposed to the smaller blood vessels of the brain. And again, that's also a nuance because there are small blood vessels that supply to very essential parts of smaller area of the brain that can cause detrimental kind of deficits too. So it just depends on where you're in overall sense. However, once we know that this is actually a stroke and there are deficits, we aggressively push therapy as soon as possible. So physical therapy, occupational therapy, speech therapy. Like a lot of times they start getting seen while people are in the hospital, and then after that evaluation, then we make the determination: does this person need to go to inpatient rehab where they get aggressive rehab? Because a lot of the times, functionality wise, we see a return in the earlier stages, so we try to be as aggressive as possible, as early as possible. And in terms of paralysis, if it's a complete paralysis, and if again a major blood vessel of the brain was affected to where 1% is like paralyzed on one side of the body, we may not be able to get as much function as opposed to if somebody had maybe some more minor motor deficits. Then with therapy, or if they had some non-coordinating issues, then that can definitely come back. So again, it's hard to answer simply because it just depends on how much of a damage has happened. But we have seen a lot, we do see a lot of improvement with therapy, but to answer that question is case by case basis, I would say.
And one other question about like these vascular scans. Is that something that's actually beneficial for patients beforehand? And can you talk a little
Say
bit
that one
about
more
it?
time, Armika.
The vascular scans.
Can you repeat the question, please?
Yes.
Okay.
Can you just talk about
So
like, the vascular scans? I know there's some hospital systems. Sorry, did you? It's a little bit of a lag.
Yeah, I did. Sorry. You're fine. So there is a couple of vascular scans. One of the ones actually I talked about already, and it's one of our initial scan, is we do a CT right away to make sure this is not a bleed. Then we do a CT angiogram, and that is a CAT scan, but it takes a look at the blood vessels of the neck as well as the head to see if there is any of those big blood clots that I talked about that we could potentially, if it's within the time frame and if it's visible, and if there is benefit to going and retrieving that clot, we can do that, then we do that. So that's a part of our stroke workup. And as far as I know, that's how other places proceed whenever they're thinking that they're dealing with strokes as well. At least that's the standard protocol is what I should say, I guess. So those are the first two things that we do. So there is another more invasive way of taking a look at the blood vessels of the neck and head, and that's called a cerebral angiogram. And that is where a neurointerventional specialist or a neurovascular specialist can go through the groin, and they go through the groin with a catheter and they loop it around to look at your carotids and the backside of your brain as well, your vertebral arteries. And that's the gold standard. However, not everybody qualifies for that. So if we don't see any abnormalities in your brain when we did that initial scan as CTA, if there's not any stenosis, meaning narrowing, if there's not any blockages, or if there isn't any abnormalities within your blood vessels that warrant that, we tend not to do that because, as I said, it is an invasive procedure and every procedure has its own risks. So those are considered on a case-by-case basis. And some of them, we do them again when we don't have an answer as to why a stroke might have happened in a young patient, because there are some certain inflammations of the blood vessels like vasculitis and things like that that could cause it, or there is some vasospasms, or meaning spasming of the blood vessels, so then they tend to like clamp up, and then that interrupts blood flow to the brain. So if we cannot find as to a clear cause as to why the stroke has happened, let's say the person doesn't have any risk factors, they're young, we can't find a clotting disorder, then we may opt to do that more invasive test, but that's not a routine test. But in the standard workup, we take a look at blood vessels of the neck and head with a CT scan as well as a normal scan as well.
Thank you. I'm just going to look in the chat again just to double check, because that was pretty much the questions that I had. Did you guys have any other questions? We'll just, you can turn on your speaker, or you can just put it in the chat like you guys have been doing already. So while we're waiting, for maybe people to put something in the chat, just like some of the things that you talked about, like some of those risk factors and things that we can actually change. Because again, genetics, we can't change so much, but there are some things that we can, like you talked about, like with the LDL, like that bad cholesterol. So making sure that you maintain like a pretty balanced diet. If you want to, talk about that, just like diet and exercise.
Absolutely.
Also, like the healthy cholesterol, which is the HDL. And just making sure that number is high as possible. One of the best ways to increase that number is by exercise. So making sure you're getting in at least those 30 minutes of exercise daily if possible, if not 3 to 4 times a week.
Absolutely. Absolutely. And that's where also, whenever we talk about these risk factors, that's where our primary care physicians and family physicians really do come handy, because again, what what would be best for us is not having anybody have a stroke, just because it can be very detrimental, such as in your mother's case, which was very unfortunate. And if some of these things that we can help and we can help minimize and mitigate before they happen, we don't necessarily even have to deal with the consequences. So most definitely, again, just like what we talked about, making sure that your blood pressure is taken care of. Sorry, my camera just paused. Blood pressure is taken care of, your blood glucose, making sure that you're staying up on that A1C, again, by making sure that your diet is very, very, including of lean proteins and vegetables and not a lot of processed foods, making sure that you're exercising, making sure that you're not smoking, making sure that, stress and other things are taken care of, just because they just tend to exacerbate the problems that are there, such as blood pressures and things like that. So living a healthy lifestyle overall would be very beneficial in terms of how to protect ourselves from this, and making sure also that we are aware of, we are aware of our body, I guess I should say, because patients know themselves more than any provider could know. So when you feel like there is something wrong, don't wait until the next day. Don't wait until a few hours from now. If you feel like something is wrong, make sure that when you go somewhere so that somebody can actually take a look at you and say, okay, this is what's happening, this is what's not happening. Then the most likely our suspicion is this, and we need to do this and that. Because again, especially with strokes, because it's a very abrupt onset for patients, and we have very limited things that we can do in the acute settings, a lot of times what we see is people do feel something is wrong, and like they're having either motor symptoms or sensory symptoms, and they tend to ignore it. And then the next day, when it doesn't go away, they come. But at that time, there are very little things that we can do to help the patient, unfortunately, because again, depending on how long that's been going on, that part of the brain is more than likely permanently damaged. And our brain is a very smart organ, and we do learn, which is the good side of all of this. Even for people that have had significant language impairments and speech deficits, they do tend to get a little bit better. I shouldn't say everybody, but they do tend to get better with the other sides of our brain, depending on, again, how large the damage is overall, kind of tend to pick up the slack, and we have to retrain ourselves, or patients have to retrain themselves to talk again, to walk again. So it happen. But again, and rather than that, we just have to make sure that our risk factors are taken care of. And we know when there is something wrong, make sure that make sure you pay attention to your symptoms, basically, because that is the most important part of all of this.
And I am going to address your question, Mr. Leon Rogers. I'm just going to ask you to clarify something, Dr. Biru. You talked about like sensory versus motor. Can you just explain that? What that means?
Sure. So sensory means you feel numb. So there is a part of your body, your arm, your face, your leg, that you are just not feeling at all. So that is also controlled by a certain part of the brain. Then we're able to localize where your deficits are. And sometimes people may not think, hey, I'm just like numb, and this may not be nothing, but it could also be something. And for some people, if you're not able to if you're completely numb, you're going to have difficulty picking things up. You're going to have difficulty coordinating things. So it's going to have its own effects down the road as well. So don't think just because your whole hand is numb or your whole face is numb that it's something simple and it may just go away. So that's what we mean by sensory changes, meaning like you just don't feel half of your body. And then again, with motor symptoms too, a lot of times all strokes are, for the most part, localizable, meaning depending on where your deficits are, we are able to have a general idea of where it is located. Strokes are hardly ever bilateral. So if you have weakness on both of your legs, or if you feel like you can't move both of your legs or both of your arms, more than likely it's not a stroke. Strokes tend to have a very particular appearance or presentation to them. But if you are feeling like, again, this is something abnormal and I have never explained anything, I have never had experience, I guess, with some of these symptoms before, make sure that you pay attention to it and don't just dismiss it or put it off.
Perfect. Someone asked, can you explain FAST for like the symptomology?
Okay, so the FAST screen is actually something that EMS uses to kind of see or mitigate if somebody may be having a stroke if they see somebody. So the FAST stands for face, arm, speech, and then T is just time to call 911. So just like what we've talked about a little bit, if you see any changes with your face, so this is half of your face being droopy, your speech is changing and you're not sounding like yourself, your words are getting slurred because again, you're experiencing paralysis from your face as well as your speech muscles that are controlled by your brain. And then your arm also, they do a quick screen to see like if you can lift both of your arms and hold them up for some time. And if you're having weakness, again, that arm is going to tend to droop or what we call drift. And then the speech changes, you could be completely aphasic, meaning you're not able to even produce any words, or you could be dysarthric, meaning you're slurring the words because you're having a hard time controlling some of the speech muscles as well. So those are the quick screen methods that EMS uses if they're concerned that somebody is having a stroke. We use a different scale and ours is more detailed because we're trying to figure out where the blood clot that caused all of these symptoms could be so that we can figure out if this is actually a stroke or not a stroke, because again, that changes management as well. So.
I don't see any other questions in the chat right now, but I also did want to mention, even for people that are at home and you see maybe a family member that has some of these symptoms, just know that they don't have to necessarily have all of those symptoms. For my mom, not in the case when she had the stroke in 2018, but there actually was another time where she had like slurred speech. And she's just like, oh no, this happened. You know, this happened once before. It's just like maybe a little bit of mucus like in the morning. I'm like, no, this doesn't seem right. And at that time, she didn't really have facial droop. So just still make sure that you pay attention. And if you suspect something, it is best for you to contact EMS immediately. I mean, it's worth, erring on the side of caution than not. Just because, in this case, like time is brain. So if you don't address it immediately, the person can end up having some type of paralysis that may not be reversible or, complications.
Absolutely. I love that so much. I'm actually so glad that you said that. We say time is brain because again, we have such limited amount of time to do certain treatments if we do believe that this is actually a stroke. And if we do get to patients on time, patients actually generally do a lot better because we're able to get to them. And again, the brain as an organ is just very powerful. And if we are able to get to it and restore blood flow, patients tend to do so much better. So we don't have any time to waste. So time is brain all the time. So whenever there is even a remote chance of a stroke, make sure that you call 911 or, you let somebody know that's around you right away so that they can, call 911, and it's better to get evaluated than not.
I think that's it. Again, I don't see any additional questions here. Any just like last minute takeaways that you want to say?
I just want to say again, thank you everybody for joining today. We truly do hope that it was somewhat informative and also motivational is what I want to say. And there are a lot of unfortunate cases, and Armika's mom being one of them, that we were not able to get to and we were not able to help, but there are a lot of patients that we can help. And more than even us helping you, you can help yourself is what the point that I want to make, because if you do what you need to do, you don't even need to see us. So just making sure that our risk factors are controlled, and if there is any concern about something being wrong, that somebody is able to make sure you're able to get evaluated and make sure that this is not anything that is emergent or urgent, is of the utmost key, making sure that you're keeping up with your family physician and your visits every time, making sure that your blood pressure, diabetes, cholesterol is taken care of. If you have sleep apnea, that's treated. If you have any abnormal heart rhythms, because that changes management in terms of medication a little bit as well, making sure that's addressed. So if you do your part, then that would be the best news to us, because then we don't even have to deal with something as emergent as a stroke. So that would be what I would say. And if you guys have any questions or anything like that, this will be up as well. And we can answer it in any shape or form, and we can put some more information on the website or whatever is needed. So yeah.
Thank you so much, Drs. Tatum and Biru. You all made such an awesome presentation and dropped amazing knowledge. We appreciate you so much. And thank you, community, for coming out and showing your support. We hope that you were able to take away some really important information for yourselves and for your family and loved ones. In the chat, if you'll notice, we have a link there. If you could fill out the survey, we just want your feedback on the usefulness of having presentations like this, and any thoughts, comments, suggestions that you have. As we are building our outreach, we want to build this for what your needs are. So please fill that out. That would be greatly appreciated. And just one last thing that we want to share with you all. I'll bring this up on your screen. So our next talk will be on June 17th. Dr. Kashari McCullough and myself, Alicia Rogers, we will be presenting about Safe in Our Skin, Fun Under the Sun, and talking about the importance of safety for children, as well as skin protection for skin of color, because we also need to take this seriously. So we have some really important information we want to share with you. So please stay tuned for that. And as always, you can keep up with current information, follow-up information. We will post the recording of this session on our website at ourgenhealth.org. So again, thank you so much for coming. We appreciate your time. And feel free to, reach out and connect with us on our webpage. And then please fill out the surveys. Hope you all have a great evening, and thank you again.
Thank you everyone for coming.
Thank you.